Hello, everyone, and welcome to today's webinar for mental health professionals, identifying and treating moral injury-based post-traumatic stress disorder in military service members and veterans, featuring Dr. Brian Klassen. My name is Astrid Masfar. I am the Senior Education and Outreach Coordinator here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You have joined the presentation listening using your computer's speaker system by default. If you'd prefer to join over the telephone, just select telephone in the audio panel and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the chat box in the control panel. You may send in your questions at any time and we will collect these and address them during the Q&A session at the end. A copy of today's PowerPoint presentation is also available for download under Materials in the Attendee interface. If you registered and paid for CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation, and the link to the evaluation will be sent to each participant within 48 hours of this webinar. You have two options to complete the post-test assessment. There will be an opportunity to complete it at the end of today's presentation, or you may complete it at a later time. Each participant will receive an email including a recording of today's webinar, the post-test assessment, and a webinar evaluation. I would now like to introduce Dr. Brian Klassen. Dr. Brian Klassen is an assistant professor of psychiatry at Rush University Medical Center and staff psychologist in the Road Home Program Center for Veterans and Their Families. As a clinician, Dr. Klassen provides individual and group psychotherapy to both combat veterans and survivors of military sexual trauma. Dr. Klassen is particularly interested in moral injury as well as psychotherapeutic mechanisms of change. I am now going to take a moment to pass the screen to our expert. There will be a brief pause while I do so. All right, Dr. Klassen, the floor is yours.
All right, thank you so much, Astrid. All right, so good afternoon, everyone. Looking forward to presenting today, and this is a topic that's near and dear to my heart, so I'm really thrilled to be able to have the chance to do this. Before I begin, just a quick word about my co-presenter, Philip Held. He had a family emergency and wasn't able to be here today, but I do want to pause and acknowledge that a lot of what I'm presenting today, a lot of the concepts, a lot of the data and ideas that we will be discussing were in large part his work. And so I do want to just pause and acknowledge that before we get started. And so we have a very ambitious agenda for this webinar. There are 4 objectives that I'd like to meet today. First is I'd like to talk about differences between moral injury-based PTSD and primarily fear-based PTSD among military service members and veterans. And the second objective is I would like to evaluate the existing assessment tools for moral injury. And the third objective is I would like to compare different evidence-based PTSD treatments as well as novel interventions for the treatment of moral injury-based PTSD. And then the fourth objective, which is really where I'm hoping to invest the most time and effort today, is really to provide some well-founded, well-grounded clinical guidance on how to address moral injury in clinical practice. And this is an objective that's very important to me, just because I have noticed that as moral injury becomes more and more of a popular concept, more and more under discussion, I think there are a lot of genuine questions and genuine confusion, especially among frontline clinicians about how to approach moral injury with your patients. Is it something new? Does it need new interventions? Do other approaches not work for moral injury? And so I'm hoping the data that I present today may address some of these concerns, and also leave you feeling that it's mostly good news, what I'm presenting. And so I'd like to start with an idea that has gotten a lot of attention in the literature on combat veterans recently, and that is that combat experiences that are Criterion 8 traumas are multifaceted, right? They comprise a broad range of experiences. And there have been 3 that have been identified that I think are important to quickly review. I think there's certainly fear components within combat. An example of this might be fear for your own life or someone else's life. You can easily see how this is the case if you're in a firefight or exposed to a roadside bomb. It's easy to see that you would fear for your own or someone else's life. But I think that there are other independent yet overlapping dimensions to combat trauma that can include experiences of loss, so witnessing or learning about the death of another person, but also moral injury-based traumas as well, the traumas that involve a dilemma between what the right course of action is, being called on to violate one's moral code. And so if we look at moral injury specifically, I think we'll start with Brett Litz's seminal paper from 2009. And the definition of moral injury, according to Litz, is that moral injury can be thought of as perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. And so there's a sense in which moral injury could include times in which an individual acts in ways that violates their moral code. It could include situations in which an individual sees others act in ways that are perceived to be morally wrong. Or it could include situations in which an individual fails to do something that he or she believes should have been done. It might be helpful to provide some concrete examples of what moral injuries might be. And in order to address this, we did a study in our clinic that we published last year where we, in a very open-ended way, just asked veterans, what are some things that they have experienced that might be considered moral injuries? The veteran told us about a time where he was called on to order an airstrike in an area where children were present. The dilemma here was that there was a high-value target who was in a compound that was very heavily defended. This individual had a lot to do with manufacture and placement of IEDs in the area. And so apprehending him, killing him may have saved a lot of lives in the long run. But again, the dilemma was, how do you balance that with civilian casualties and the casualties of children? Another veteran spoke to us about being part of a convoy that ran over children. And unfortunately, this is a very common scenario for veterans of more recent wars. And the dilemma here is that, the moral code many of us go by is that it's wrong to harm children, or if you do harm someone, you should offer to help them. But that comes into conflict with a different moral code, a moral code that says you must follow orders, you must put your safety and the safety of your unit first. And so slowing down or stopping a convoy can often leave them vulnerable to ambush or attack, which may cost lives. And so the dilemma that this veteran was speaking to is, not knowing what the right course of action was, or possibly there was no right course of action. Another veteran described how he was called on to shoot and kill a young boy with a weapon. Now, this was a justified act according to the rules of engagement for that area of operations at the time. But for the veteran, the dilemma again was it's wrong to harm children. It's wrong to do violence to children. But yet, at the same time, he was called on to act as a soldier, act to protect himself and his unit. Another veteran told us how he fired several shots into a crowd of civilians, and he was very clear that this was unprovoked, this was a Geneva Convention violation, that there was no justification for this beyond just his own rage and disgust at the people that were around him. Another veteran spoke to us about how he witnessed fellow service members sexually assaulting local women, and that he knew that this is something that shouldn't happen, something that should be reported, but he did not because he feared reprisal. And there are certainly dozens of other examples that we could give here, but I do think it's striking that even with such a small sample here, we just have 5 examples, we can see that there's very different contexts to each of these events. There's very different extents of responsibility and intent. And I think the other thing this shows is that these are often very emotionally provocative situations that are difficult for the veteran to disclose, but also difficult for the therapist to know what to do with in therapy. So there's a convergence in the literature among expert opinion, and this is bolstered by empirical work, on the clinical sequelae of exposure to morally injurious events. And I think it's helpful to distinguish between core signs of moral injury and secondary signs. So core signs of moral injury might include things like guilt and shame. Veterans might say things to you or hold beliefs like, I should have made another decision, or I'm a monster, or I'm broken. Often, exposure to moral injury can result in spiritual struggles. So veterans may believe things or say things to you like, how could God allow this to happen? I'm beyond forgiveness. And I should pause here to say that moral injury is not necessarily tethered to any sort of religious or spiritual tradition, and that sometimes these struggles can express themselves through existential dilemmas. So life is meaningless, or my life is meaningless because of the things I saw or because of the things I had to do. Sort of a related issue is loss of trust, that if a person is capable of violating some bedrock moral principles, or if other people are, then veterans might say to themselves, how can I trust myself ever again? How can I trust others ever again? And so from the core signs, you can easily see how these naturally lead to the secondary signs of moral injury. And these are often the more sort of overt presentations that you may see. And that this can result in sadness, anxiety, social alienation, intrusive thoughts, or anger. And so in the clinical assessment of moral injury, I think it is important to know that there are a variety of psychometrically sound, so reliable, valid instruments of various domains of moral injury. And I think it is helpful to distinguish between those instruments that are best suited for measuring exposure to potentially morally injurious events, and those instruments that are better suited for measuring the clinical sequelae or the clinical outcomes of exposure to morally injurious events. And so the first set are the moral injury events scale, or the MICE for short, and the moral injury questionnaire military version, the MIQ for short. Both of these instruments are a global assessment of potentially morally injurious events. The MICE is comprised of 3 factors. So there's a factor for transgressions of self. So an example item from that might be, I violated my own morals by failing to do something that I felt I should have done. An example of the next factor, transgressions of others, might be I saw things that were morally wrong. The next factor, perceived betrayal. An example item might be, quote, I feel betrayed by leaders I once trusted, unquote. The MyQ, as you can see, is a unidimensional measure. It's not comprised of any factors. But a sample item from the MyQ might be something like, quote, I did things in the war that betrayed my personal values, unquote. It's important to note that neither of these scales require the respondent to tether their responses to a specific focal, morally injurious situation. Rather, they are global assessments of any sort of perception of exposure to a morally injurious event. Now, the two instruments in the second camp, the ones that assess the clinical sequelae or the aftermath, clinical aftermath of exposure to morally injurious events, are the expressions of moral injury military version, or the EMIS-M, or the moral injury symptom scale military version, the MIS-M. The EMIS-M is comprised of two factors. There's a self-directed factor, which includes items such as, quote, I am ashamed of myself because of things I did and saw during my military service, unquote. So you can see how that harkens back to one of the core elements that we reviewed of moral injury, of guilt, of shame. The other factor, other directed expressions of moral injury. A sample item might be, when I look back on my military service, I feel disgusted by things that other people did. So you can see how that harkens back to anger, to social isolation as features of moral injury. Last scale, the moral injury symptom scale military version, the MIS-M, is comprised of 10 theoretically distinct subscales, although there probably are higher order factors there. They may be theoretically distinct subscales. I don't think they're empirically distinct, but further work needs to be done on that. And they measure things like guilt, like anger, spiritual struggles, and the like. So some example items from the MIS-M might be, quote, some things I did during the war continue to bother me, unquote. Another item, taps more spiritual struggles, might be, quote, I wonder what I did for God to punish me, unquote. Or another, quote, I have a good sense for what makes life meaningful, unquote. Now, in reviewing these instruments, if it hasn't become clear already, I think they're all alike in that they do not require the responses to be linked to any specific focal moral injury. And there may be good clinical reasons for doing this, but I do think it is important to be aware that that is what you are assessing. It's somewhat akin to giving a PCL5 and not tethering the responses or not linking those responses to a particular index trauma. These are global assessments. And I think, despite the fact that these are psychometrically valid instruments, psychometrically reliable instruments, I wouldn't consider them diagnostic. I would consider them as part of a larger battery. But I do think they are useful screens for opening up a conversation about some of these issues. You know, an example of this might be, you know, in a clinical interview, you might say, you know, I noticed you endorsed an item about violating your morals. That sounds really important. Can you tell me more about that? As an invitation for the veteran to share with you some things that they consider morally injurious. I think with any clinical assessment, it's helpful to be aware of some of the prevalence rates. I think the problem with moral injury is that it's difficult to do so because there are scant data out there. So we don't really know, don't really have a good idea what the overall rates are. I think one exception to this is Blair Wisco's study that she published last year, in which she took a nationally representative sample of combat veterans and administered the moral injury events scale. So you can see the three subscales: transgressions of self, transgressions of others, and then betrayal. And that you can also see that among a national sample of combat veterans, that there is a significant minority of veterans that do endorse exposure to morally injurious situations, right? That between 10 and 11% endorse acting in ways themselves that violated their moral code or moral principles. And that between 25 to 26 of veterans say that they've seen others do so, or that they've had experiences of betrayal. So it was an interesting question for us because we wondered in our clinic what would happen if we took this scoring method and applied it to veterans who were treatment seeking, right? Because I think something to be clear about is that in Wisco's sample, these were not treatment-seeking veterans. These were nationally representative, but there was no sort of inclusion-exclusion about psychiatric diagnoses or treatment-seeking. And so in our program, this is the Road Home program, these are veterans with a confirmed diagnosis of PTSD that are treatment-seeking and that are seeking not only treatment, but they're seeking a 3-week-long intensive outpatient program that's trauma-focused, right? So this is a very select sample, probably doesn't generalize to everyone, but I still think this is interesting that when you take the same scoring algorithm, you know, the rates of moral injury endorsement climb considerably, right? We have over 60% of these veterans that endorse self-transgressions, that they've acted in ways that have violated their morals. Over 75% say that they've seen other people act in ways that violated their morals, and that experiences of betrayal are quite common as well. And so while these data are hard to interpret, I think one takeaway that I have is that rates of moral injury endorsement among treatment-seeking veterans are likely much higher than they are in a general sample, and that for those of us that work with veterans with PTSD, moral injury and moral injury exposure are things that are interwoven into what we do. So I'd like to refer back to Brett Litz's paper on moral injury now. And in his paper, he proposes a causal framework for moral injury, and that I think is worth a close look. And so basically, we start with a transgression, which, as we've seen, could include things like acting oneself, seeing other people act in ways that violate morals. But that the key piece next is that the transgression results in some sort of dissonance or conflict, right? And I think an easy way to understand this is if you think about the example earlier about the veteran in the convoy, you know, that you grow up with a certain principle of it's wrong to harm children, but then you have this other competing set of principles that you have to keep yourself safe, you have to follow orders, you have to keep your unit safe, and that these two principles conflict in a way that is not easily resolvable. And so one possible outcome of that, according to Litz, is that a person can begin to make stable and internal global attributions about themselves. And so one way of resolving it might be, well, I did that because I'm a monster, or I did that because I'm evil, right? Which, once those attributions form, It's easy to see how that leads to shame and guilt and anxiety, which then leads to social withdrawal. And just a quick pause on the social withdrawal piece. I think this is important because one of the things it does is it may deprive veterans of corrective feedback about these appraisals and about their experiences. And I think furthermore, when we talk with veterans about morally injurious experiences, we heard this in the study that I was mentioning earlier, is that many of them feel that their moral injuries are like an infectious disease, almost akin to leprosy, and that if they share some of their experiences, that it would sort of bother or traumatize others, right? And so they sort of keep these things hidden. They withdraw socially in order to protect people from these horrible things that they've witnessed and been involved in. But you can see how social withdrawal then leads to a failure to forgive and self-condemnation, which then leads to sort of the hallmark kind of clinical sequelae of exposure to moral injury, which might be chronic intrusions, avoidance, numbing, self-harming, self-handicapping, demoralization, which then creates a feedback loop, which leads us to the attributions again. And so there's a sense in this model in which the attributions strengthen further, they crystallize. There's also a sense in which the attributions a person makes, the meaning they make of the morally injurious events they participated in or experienced, that these are really a key component of understanding the clinical presentation of folks with moral injury. And this is, in fact, what we see in the literature. We did a study here with our clinic data in which we showed that exposure to morally injurious events is measured by the morally injurious events scale, the MISE. That exposure to morally injurious events, that the relationship between these and trauma-related psychopathology, so PTSD, depression symptoms, was mediated by negative post-traumatic cognitions. So cognitions like, there was something about me that caused this trauma to happen, or I can't ever feel normal emotions again. Those sorts of beliefs mediate the relationship between morally injurious experiences and symptoms. And I think one thing this model does is it shows in kind of broad strokes that Litz's postulation that appraisals, that attributions are central. I think it does validate that postulation that Litz made. Joseph Currier found a similar thing in that morally injurious experiences, the relationship between these and things like PTSD symptoms, depression symptoms, suicide risk was mediated by the meaning made of the morally injurious situation, right? So again, appraisals, beliefs, these are the things, it's like the critical bridge between the experience and the outcome, the symptoms. And so this leads me to the conclusion that at this point in the moral injury literature, appraisals are the best supported clinical target. Now, I should say these models that I showed you, they don't account for all the variance in the clinical sequelae and the outcomes. So I think there's certainly room for other mechanisms. And I think indeed we may find others. But at this point, my attention is on appraisals. My attention is on a person's beliefs and the meaning that they have made of the situation. And so I'd like to switch gears now and talk more about treatment, about sort of the clinical approaches towards moral injury. But before I do that, I'd like to just make a quick digression, just for context. So the moral injury literature is quite new, really only a few years old, at least in its current form. It's an old idea, of course, but I think in current mental health research, it's still pretty new. And a lot of the studies that I've seen lately, and a lot of the studies I think we're likely to see for at least the first few years, have to do with correlating exposure to morally injurious events with certain clinical sequelae. And there are two ways to do that. I think one way is to try and link morally injurious events with certain symptom criteria, certain DSM-5 diagnoses. So this has certainly been done, and there are certainly published papers that show this relationship between exposure to morally injurious events and PTSD, major depressive disorder, anxiety disorders, substance use disorders, right? These papers all exist. But I think another way to do this, go about this literature, is to relate morally injurious event exposure to transdiagnostic clinical constructs of interest, right? So these are things that may be part of the DSM-5 diagnosis, but they don't have to be. So things like guilt and shame, suicidal ideation, anger, poor social support, hopelessness, pessimism, functional impairment. These are all constructs that have been shown to relate to moral injury exposure as well. The other point I'd like to quickly make is that, if you think back to the 5 examples I gave earlier about what the veterans have said to us about experiences that they find morally injurious. And if you think of this blue oval as sort of the boundaries of what is a morally injurious experience, I'd like to point out that some moral injury is also a criterion A trauma. And symptoms arising from that may be best captured by the DSM-5 diagnosis of post-traumatic stress disorder. But this certainly isn't the case for all moral injury. But there are moral injuries that might not be criterion A traumas, and that might be better captured by diagnoses such as major depression or anxiety disorders or substance use disorders. But I also think it's the case that there might be moral injury and morally injurious experiences that are not captured by DSM-5 diagnoses, but still result in clinically significant distress and impairment. Right? So that's the area of the blue oval that's not eaten up by the Venn diagram. The last point I wanted to make here is that the majority of clinical protocols, the majority of empirical work that's been done on the treatment of moral injury has really focused on this piece here, which is the question of what do you do when the morally injurious event is also a criterion A trauma, and that what you're treating the person for is PTSD. And so the goal of treatment is to reduce PTSD symptoms, right? What sorts of approaches, what sorts of protocols are best suited for that purpose? And so I'm going to try, I will warn you all, I'm going to try to do a lot with this slide. And I think giving each protocol a fair, well, anything more than a superficial take, which I'm about to do, is outside the scope of this presentation, so I apologize beforehand. I think my intent in this slide will become apparent, hopefully in the next minute or two. But I think it's important to know that there have been a proliferation of protocols and treatment approaches for moral injury recently. And I think it's helpful to distinguish between those protocols that have been specifically designed for moral injury. So things like adaptive disclosure, things like building spiritual strength, things like impact of killing, between protocols that are established and very well researched frontline treatments for PTSD. And I think the attention there has been more on do these treatments like cognitive processing therapy and prolonged exposure, do they apply equally as well when the criterion A trauma is also a moral injury? I have some data to speak to that we'll get to in a minute. But first, I would like to just kind of review each treatment in turn. And so we'll start with adaptive disclosure, which contains a component of psychoeducation. So framing a person's troubles as the impact of operational stress and normal given certain circumstances and context. There's a component of imaginal exposure and processing, so working with a veteran or service member to choose a focal moral injury that's then processed in an exposure therapy method. So part of adaptive disclosure to guide the veteran or service member in a discussion with an imagined benevolent moral authority. So this is a technique that's sorted out of the Gestalt tradition of two-chair exercises. So it's a practice of disclosure, a practice of imagining what this benevolent moral authority might say to you about what you've done and what you need to do now. And then lastly, there's an emphasis on making amends. So, very clearly saying we can't do anything about the transgression that occurred, but the question is, what do you want to do now? What kind of life do you want to live now? Next protocol is building spiritual strength. This is an interesting protocol. It's written for chaplains, and it's also intended not necessarily to be delivered in a mental health setting. It might be delivered in churches or community centers. And in building spiritual strength, the idea is to ask people to reflect on how trauma and how moral injury have changed their relationships with God or a higher power or their sense of spirituality. And asks people to struggle a little with the idea of, a loving God with the presence of evil in the world. And I think what happens in building spiritual strength that's very important is this encouragement of active coping, right, through prayer, through journaling, through seeking support from a spiritual community of people. But there's also a discussion of forgiveness to say, we can't do anything about the transgression, but can you forgive yourself? Can you forgive the people involved? Now, cognitive processing therapies, one of the more sort of venerable, very well supported empirically treatments for PTSD, and that includes elements of psychoeducation. But the bulk of the treatment is really about Socratic questioning, which is a method of helping people sort of remake their appraisals of the situation, right? Making sure that they're well-founded on facts and evidence and appropriate context. And that there's explicit cognitive restructuring regarding trauma-focused beliefs, so how a person behaved in a particular situation or what they believe about why the trauma happened to them, as well as cognitive restructuring of present-focused beliefs about not being able to trust, about not feeling the world is safe, about not feeling like a good person deep down. All these are addressed in treatment. The next protocol is the impact of killing, and this is a brief protocol that's meant as a preparatory treatment for an evidence-based protocol, so CPT or PE, or it could be adjunctive, administered alongside. But there's psychoeducation, there's explicit cognitive restructuring there as well about a person's beliefs about having killed or having taken life in combat. There's also discussion of making amends, similar to adaptive disclosure. And similar to the other treatments, there's an emphasis on self-forgiveness. Then the last protocol will address prolonged exposure. Again, one of the venerable frontline treatments for PTSD, very thick empirical support. Includes an element of psychoeducation, breathing retraining, bulk of treatment is really based on an in vivo exposure hierarchy. So, very simply, this is about helping veterans and service members re-engage with activities that they've avoided previously. And so with moral injury-based traumas, this can look a little different. So some examples of in vivo exposures that we've used is being around children again, maybe caring for children in your own family, or taking your own children to a park, right? You can see that some of the folks whose traumas I reviewed earlier, they find that very provocative, but also what an incredible opportunity to relearn and recalibrate. The other component of prolonged exposure that's important to mention is this imaginal exposure and reprocessing. So again, helping a veteran focus on a focal situation, processing it in detail, building context, helping them reappraise what happened and come to a new understanding of what happened. And so I think along with this kind of proliferation of treatment protocols, I think there has been a lot of controversy over sort of which is the sort of preferred approach, or that certain protocols may not work for certain sorts of folks. I think the direction I want to go with this is that, if you look across these protocols, I'd like you to notice something. And that is, if you think back to Litz's model, and then the two studies I reviewed, we said appraisals were at the heart of sort of the clinical presentation of moral injury, right? That somebody had something happen to them, they've construed it in a certain way, they've understood it in a certain way, and that is what has created symptoms. And so how do you work with a person's appraisals? Well, two ways that I know of. Is that we can do exposure therapy with them and help them kind of relearn through that method, right? And you can see that adaptive disclosure, prolonged exposure, both make use of imaginal exposures. Or we could do explicit cognitive restructuring, help a person understand what their thoughts are, helping a person understand and rebalance what their thoughts are, right? And so you can see that there's explicit cognitive restructuring and cognitive processing therapy and impacted killing, right? And so I think to the extent that these treatments are successful, it's that they're relying on certain principles of change that are, apparent in Litz's model and in the empirical data that I've shown. And so where I'd like to take this next is, just to review some practical, concrete skills for approaching moral injury in the context of therapy that really should apply no matter what approach you use, right? And they're knowing where to focus, it's building appropriate context, and then avoiding premature reassurance. And so I think knowing where to focus is an important one to start with, because it's a dilemma of many therapists who are working with veterans with moral injury. And I think it's a dilemma because many veterans will come in and say provocative things like, I'm a monster, right? And ostensibly, this is what's driving a lot of the distress. So I think it's quite natural that therapists kind of gravitate towards helping a person challenge and reappraise a belief like this. I would submit to you that this is maybe premature and it could be somewhat of a mistake. I think the reason for that is, that there are often deeper beliefs that are tethered to a specific event that often are the genesis of those more kind of global distress-causing beliefs. And so the way we explain it to the veterans is that, if you garden and you want to get rid of a tree or you want to get rid of a weed, you don't do it by cutting the leaves or the branches. You have to go at the root, right? And so oftentimes, I think a mistake that many therapists can make is latching on too quickly to these kind of global distressing beliefs and not doing enough digging and not enough exploration. Give an example quickly. If you think back to the veterans I spoke about earlier who shared morally injurious experiences with us, you know, the individual who called in an airstrike when children were present, his event-specific belief may have been, I should have disobeyed the order. Like, I should have tried harder to find a way around this order. I didn't really want to do this. But his present-focused belief, one that ostensibly might come up in therapy, is that I can't trust people in authority. I'm getting in trouble at work. I get in arguments with the police. I can't stand being told what to do. The individual that spoke about being in a convoy that ran over children, he might have a belief like, I should have stopped to offer help. But in therapy, he might talk about sort of being cold and callous. But with exploration and digging, you can sort of arrive at these event-specific beliefs. The individual who shot and killed a young boy with a weapon might have a belief like, I should have fired a warning shot. I should have tried harder not to take that boy's life. I should have seen if there was any other option. The present-focused belief might be only a monster would do what I did. The veteran who fired several shots into a crowd of civilians might have an event-specific belief, I shouldn't have done that. But the present-focused belief might be, God won't forgive me for what I did. And I just want to quickly point out, you know, the difference between the event-specific beliefs and the present-focused beliefs is, notice the event-specific beliefs, they don't always have to be structured this way, but it's I should, I should, I should, I shouldn't, I should, I shouldn't. It's about sort of person's specific behavior in that situation. But the present-focused beliefs are often more global, more focused on present-day functioning. And so once you've determined a focal morally injurious event, and you've discovered a present-focused belief about how a person acted in any given situation, I think now you're free to sort of naturally engage in context building. And I say this because I think sort of one of the issues with a lot of veterans with sort of morally injurious traumas is that, you know, they're very focused on particular parts of the situation. But I think through context building and through asking them for details of the situation, you know, that there is more to the story and a kind of richness and detail, more context that may help them think differently about what happened and reappraise their role, reappraise what happened. So you might be wondering, well, how do I go about this? And I think it's important to distinguish between context building questions and the more challenging questions. I think in context building questions, the goal is simple. The goal is just to get more detail, get facts. So you might ask, like, well, what year was this? Where were you? What was your role? What kind of training did you have? Who else was there with you? What happened just before this? What happened afterwards? Example of why this is important is because, you know, I'll sort of give an example to, you know, vets I work with about, you know, if a convoy rolls over an IED and you develop a belief of I should have spotted the IED, you know, like what sorts of things do the veterans become curious about to sort of help a person appraise this belief? And then they start asking questions like, well, was this Iraq or Afghanistan? Was this a paved road or a dusty mountain road? What kind of IED was this? And it matters whether it was 2005 or 2012, because the IEDs change, they become more sophisticated. It matters what kind of training you had. It matters where you were sitting in the convoy. It matters how fast the convoy was moving. Right? But all these things aren't fully integrated into the context, oftentimes. So I'll skip ahead here to kind of a nice clinical example that shows how context might build, you know, even through a treatment like prolonged exposure. And So this is a veteran that we treated in our clinic, and sort of morally injurious trauma was that he shot and killed a young girl who was outfitted with a bomb vest, who was approaching this checkpoint, and he tried basically everything he could to get her to stop, but eventually he had to shoot her and end her life, and then the bomb vest exploded. He thinks it was remote detonated. And so this exchange occurred in session 4. And if you're familiar with the prolonged exposure protocol, you'll know that this was after one session of imaginal exposure, and this is during the processing. So the therapist says, "How was that for you today?" The veteran says, "I'm really fucking angry right now." "Oh, tell me more." "I was in that country to help people like her. I wasn't there to shoot little kids. She was helpless. I didn't go into that situation wanting her to die." And then he begins to tear up and access some natural affect, some sadness and grief. "What did you want to happen that day?" "I don't know, but not that." This exchange occurred the next session, so another session of exposure, another processing. Look at the level of detail he's able to integrate into the story. "I feel sick about it. I have this feeling like if I had composed myself, if I had taken a better shot, I think sometimes I could have gotten in the prone position. I could have shot her legs that way. I could have just taken time. I could have wiped the sweat off my face. I could have taken a solid shot. My command wanted us to put the wire up to keep children away from the checkpoint, but we didn't do it because kids were playing there and they had nowhere else to go. If we had listened to our mind instead of our heart, then she wouldn't have been able to get close." And the therapist says, "If you could go back, what would you do differently?" I think about that a lot. I could have done something to give her a better chance. I think so, but I don't know. I don't know. So you can see him beginning to struggle with, was there any other option? What was my intention? And then this exchange occurs in session 8, right after there's been significant symptom remission. And look at how he understands the event now. So the therapist asks, "What do you think has changed since starting PE?" He said, "I was part of a fucked up situation I didn't want no part of. I realized I didn't want to be part of that. I didn't want that to happen. It lets me know that it happened, and I probably could have done some shit that might have changed her a little bit, but I know that girl may have died all the same. It's shitty. I had to be a part of that, but it happened." And so look at the level of context he's able to achieve, even within a few sessions. Because I show the exchange from session 4, the first one, because, and I know this veteran, and I think it wasn't until that moment that he had actually thought about what he wanted to have happen that day. Because I think if you had asked him before prolonged exposure, he would have said, "Well, I shot and killed a little girl, end of story. That's all there is to it." But you start to see him add naturally things about intention and responsibility and sort of other factors at play in this situation. The last piece I want to cover very quickly, because I know we're running out of time, is avoiding premature reassurance. And I think this is a natural thing that many therapists do, because we've talked about a lot of emotionally provocative situations now. And I want to just submit that prematurely reassuring veterans who are struggling with moral injury is a problem, because I think it prevents them and blocks them from doing the more deeper processing and reappraising that they need to do. So here's a hypothetical example. This is the previous veteran. So the therapist, "How was that for you today?" Veteran, "I'm really fucking angry right now." Then the therapist says, "I know you didn't want to shoot that little girl, but you had to keep your unit safe. You did the right thing." Right? All perhaps well-meaning and true, but look at how it sort of stalls his processing. How can you say that? "I don't see that you had any other options. If you did shoot her, she would have gotten too close and maybe killed some of your friends." And then the veteran replies, maybe you're right, but I still feel like shit. Stuck. So the takeaways I'd like to leave you with are, I think in working with moral injury, it's important to develop a focus on a specific event. It's very akin to trauma-focused treatment that way. That unless you're doing this, it's hard to get the sufficient detail, the sufficient affect in order to reappraise the event. And that you're building context, you're asking questions, you're being curious, and that you get those details, and that you don't challenge too early, that you don't prematurely reassure, you don't make meaning for the veteran, but you allow them to do it themselves. And I think in the interest of time, I have a couple things to present, but they're kind of complicated and hard to interpret. And so I think what I will do is invite questions. Now I think we have a few minutes, I can take a couple. But I would like to say that I would be thrilled to hear from any of you, feedback about this presentation, things that you are outraged by, or things that you really liked. I would really welcome further engagement over email. So thank you so much.
Awesome. Thank you very much, Dr. Klassen. We're now going to give everyone an opportunity to ask any questions. Again, please submit your questions using the chat box in the attendee control panel. So we'll just give everyone a minute to ask any questions. We did not get any questions, but we did receive a comment saying, great job from the Emory Healthcare Veterans Program.
Thanks, Barbara. I appreciate that. Glad you were able to make it.
Okay, if there aren't any other questions, we're going to go ahead and wrap this webinar up. The CE code for this webinar is AMPO, so if you are seeking CE credit, please take note of that. Thank you, Dr. Klassen, and thank you to our participants for attending today's training. You will receive an email shortly that includes the link to the webinar recording, the post-test assessment, and a webinar evaluation. An opportunity to complete the post-test assessment will also occur after these few announcements. Our next ADA Live webinar will be on Thursday, November 8th at 12 p.m., Empowering Families in the Face of Pediatric Acute Onset Neuropsychiatric Syndrome, featuring Dr. Lynn Sicklin and Tamar Chansky. If you're not an ADA member, we invite you to view the many membership benefits that ADA has to offer. We would also like to invite you to save the date for ADA's annual conference on March 28th to March 31st in Chicago next year. On behalf of ADA and our presenter, we thank you for joining us.